during this class. So one of the commonest entities that you will come across is inflammatory lesions of the ovary or oophorytes. And this is almost always secondary to salpingitis, then an ascending infection, but it can also be a consequence of peritonitis or systemic inflammatory disease. For example, if you have tuberculosis and you have widespread tuberculosis, then it can end up as a pelvic inflammatory disease or tuberculosis in the ovary, in the fallopian tubes, in the endometrium, and so on. Then oophorytes may often lead to abscess formation. So you have either an ovarian abscess or a tubo-ovarian abscess. And of course, if it's chronic oophorytes and bilateral disease can lead to extensive fibrosis and subsequently infertility. So this is just a pictorial representation of pelvic inflammatory disease. When you have involvement of the endometrium, so you have an endometritis, you have a salpingitis, inflamed fallopian tube, and an inflamed ovary, then we call this pelvic inflammatory disease. And it's often ascending, okay? So it may ascend from the lower female genital tract and has many causes, either as a sexually transmitted inflammation or a consequence or a complication of a UTI. So lots of possibilities in terms of microorganisms, then ascending into an endocervicitis, endometritis, can involve the parametrium, and then all the way through the fallopian tube to give us salpingitis, and then finally end up with an oophorytis. And if there is abscess formation, then we'll have either a tubo-ovarian abscess or pelvic abscesses. So this is sort of also a schematic diagram. And of course, from a pelvic inflammatory disease, you can end up with systemic spread and end up with systemic sepsis. So this is an image to show the ovary is a bag of pus. You can see the yellow stuff in this sort of cystic space, or a collection of pus in the ovary. So this is an ovarian abscess. Histologically, could be suppuration, acute suppurative salpingitis, but you can also see lots of macrophages in between. When the pus cells kind of start to get cleared away and you end up with lots more macrophages, then we call it xanthogranulomatous salpingitis. And on occasion, you may even have other microorganisms, like in this case, actinomyces. And this is often ascending from an endocervicitis or an endometritis, particularly in women who have IUDs, actinomyces, endometritis, endocervicitis is not uncommon. And you may end up with abscess formation in the ovary and fallopian tube with recognizable actinomyces in the center of the micro abscesses. So we look now at what I'm not covering today is ovarian ectopic pregnancy in the fallopian tube and ovary. I think that will be covered elsewhere, if I remember correctly, on diseases of pregnancy. So it's not included in this lecture. So non-neoplastic ovarian cysts, a whole variety of cysts occur in the ovary. They're non-neoplastic. Some really just an extension of the normal structures that we find in the ovary, like follicular and luteal cysts. They are common. Actually, some of the commonest cysts in the ovary are follicular and luteal cysts. Measure anywhere from 1 to 8 centimeters, and they are for follicular cysts. They're lined by follicular cells or luteinized cells. When they are small, they are asymptomatic, tend to involute on their own, but they may rupture, causing peritoneal reaction, generally inflammatory reaction, bleeding, and pain. And then that's when we know they're there. And of course, if they're large, 8 centimeters, then it may even be a palpable ovarian mass. Chocolate cysts are blood-filled cysts, often due to endometriosis of the ovary. So you have ectopic endometrial tissue in the ovary, and it goes through the same cyclic changes that endometrium in the endometrial cavity goes, and the cyst just becomes filled with old blood. Okay, and this is an example on an ovarian endometriotic cyst. We call it chocolate cyst because of this dark brown chocolate colored contents that are generally old blood. So you'll see this quite often in your reading. Chocolate cysts, they're simply endometriotic cysts in the ovary. And the way they form is you have foci of, these are ectopic endometrial glands in the ovarian stroma. Then the cyclic old and new hemorrhages, then involution cleared away by macrophages that tend to be hemosiderin-laden macrophages, and often there's a surrounding zone of inflammation and fibrosis, okay, sort of walling off the cyst. And this is an example of a non-neoplastic follicular cyst. You can see the cyst there. It has a somewhat thick fibrous cyst, and it's unilocular, so it has one space, okay, with a sort of shiny cyst lining. Okay, so that's a follicular cyst. And this one is about just 1.5 centimeters in diameter. And the histology of the follicular cyst, you can see the compressed ovarian stroma, and then the cyst lining, granulosa cells or luteinized follicular cells, fairly uniform and regular. And often, if they're small, they'll involute on their own, but if they're large, they may need to be surgically removed. These are two corpus luteum. One, the larger one, is post-menstruation. Okay, after the corpus luteum, after the rupture and release of the ovum, then the cystic space may be filled with blood, and that's the way it would look like. Sometimes they can be troublesome and painful, and even rupture and cause the peritoneal reaction. Often they are small and involute, like this one is an old one from a previous menstrual cycle, and it's already involuting. Hemorrhagic corpus luteum cyst, these are very frequent. It's something we see very often in histology as a histological specimen because they present with pain, sometimes with hemoperitoneum. Especially if they're large, they may rupture and cause hemoperitoneum. So they're taken out. So again, very similar to a chocolate cyst in terms of appearance, but not on histology. And this is how it looks like on histology, a hemorrhagic corpus luteum. You have hemorrhage as the contents. Then the wall is thickened luteinized cells. Okay, so thick, sort of this undulating wall, and then often an inflammatory cell reaction. And then we come to polycystic ovarian disease, so-called Stein-Leventhal syndrome. It's an important cause of infertility, as you shall learn when you go into your OBGYN. And the polycystic ovary is associated with excessive production of androgens, with increased conversion of androgens to estrogens, complicated by insulin resistance and inappropriate gonadotrophin production by the pituitary. So the whole axis just goes out of whack. Remember, when I started, we said that the ovary, the cyclic production of ovarian hormones is controlled by the hypothalamus pituitary axis. Okay, so when the ovary itself is producing too much androgens, which are the precursor of estrogens, then the feedback axis, then you get inappropriate gonadotrophin production. The ovaries are large, they are white, they have numerous subcortical follicular cysts, measuring anywhere from 0.5 to 1 centimeter in diameter, and they are covered by thickened, fibrosed outer tunica. And the follicular cysts do not convert to corpora lutea. Yeah. So there is no ovulation. Okay, so that's why these young women are infertile. So generally, they tend to be young women who present with polycystic ovarian disease. They have oligomenorrhea or inadequate menses, very scanty bleeding. They may be irregular. They tend to be obese, again because of the hormonal disorder that is going on, and because of the excess production of androgens, they end up with hirsutism or abnormal body hair. And this is how an ovary will look like grossly, not numerous cortical cysts in various stages of involution, okay, on histology, and then ultrasound, you can see all the cortical cysts of various sizes. So that's that. It's an interesting syndrome, Stein-Leventhal syndrome. So you can read more about it as a clinical entity. Okay. So let's look at the neoplastic lesions of the ovary or tumors of the ovary. And please feel free to stop me at any point if you want me to explain something. Okay. I want to stop this. Hide it. It's not going away. Okay. So generally, ovarian tumors have certain things in common in terms of presentation. Okay. They are common. Fortunately, majority, up to 90% of ovarian tumors are benign, and most occur in fairly young women, 20 to 45 years. Having said that, ovarian cancer is the second most common malignancy of the female genital tract after cervical cancer. Cervical cancer is about 7 times more common than ovarian cancer. And majority of these tumors are derived from the surface epithelium, okay, the coelomic epithelium that we saw initially in the first diagram of the ovary. And the CA125 is a tumor marker for surface epithelial tumors, so remember that. Malignant ovarian tumors present generally at a late stage. So it's acquired disease, and because they present at a late stage, they are associated with high mortality rate. Known risk factors include nulliparity, family history, specific inherited mutations, such as BRCA1 and 2 genes, prefer an increased risk for ovarian cancer. Okay, so this is a table showing a basic classification of ovarian tumors. And because the ovary is such a complex organ, the classification of ovarian tumors can also look very complex and daunting, but we tend to group them in terms of where they arise, the site of origin in the ovary. Okay, so for example, for tumors that arise from the surface epithelium, okay, that's the biggest group, and there are quite a number. And then tumors that arise from the germ cells, tumors that arise from the sex cord stroma, miscellaneous that just defy classification, and then of course there is metastatic disease, metastatic tumors. Okay, so this is a general basic classification of ovarian tumors. So if you don't remember anything else from this class or this segment, remember this basic classification. So let's look at some more detail for surface epithelial tumors, and there are about 5 examples. You can see there the majority, they form or comprise 60 to 70% of all ovarian tumors, generally age group 20 years and older. The germ cell tumors tend to be, they are less frequent, about 20%. On the outside, and they can start anywhere from 0 or early life all the way to later older women. Sex cord stromal tumors, which include granulosa thicker cell tumors, and so on, account for 5 to 10% of tumors and can occur at any age. And then there's the group of miscellaneous tumors. Okay. Well, I can't get rid of this. Anyway. And then there is metastatic disease that form about 5%. And this can occur, the age of presentation is variable. So let's look at now the surface epithelial tumors, and we'll start, we'll go through this list: serous, mucinous, endometrioid, clear cell tumors, and Brenner tumors. Okay, and then we'll just go down the list. So serous ovarian tumors, they're actually a spectrum of tumors, from benign, borderline, or sort of in between, and then the overtly malignant serous ovarian tumors. They tend to be large tumors, spherical masses, and of cut surface. The benign tumors tend to just have to be unilocular. Larger ones may be multilocular with daughter loculi in their walls, which contain clear watery fluid, and that's why we call them serous, clear, because they contain clear watery fluid. Malignant serous tumors have solid areas. They tend to have more solid areas, but they are still cystic and may contain exophytic as well as intracystic papillary projections. And I'm showing here a unilocular cyst, thin-walled cyst with solid areas, and this sort of cauliflower projections on the surface. so which on histology look papillary. Okay, so papillary projections into the lumen of the cyst. So this is a huge serous cystadenoma. So very thin, translucent capsule, and you can see some fibrous divisions and lots of thin-walled blood vessels that run through the wall of the cyst. Another example, sort of this grayish, bluish, opalescent cyst wall. Okay, a serous cyst which will contain clear, watery fluid, and this one you can see is about 10 centimeters in diameter. Another serous cyst, this one is multiloculated, so it has multiple cystic spaces, but still the wall is thin and opalescent and generally smooth, but then you have solid projection into one of the locules of the cyst. Another example, and this is a malignant version of the tumor. And you can see through this thin capsule of the cyst what looks like solid areas. Okay, but of course you have to open it to see. Okay, and when it's opened up, you can see these solid cauliflower projections into the cyst wall. Okay. And the more of this that you have, the more likely that you have carcinoma. So how we name them is papillary because of because of the papillary projections, serous because of the type of epithelium, okay, and also the fluid that is produced by these cells, and then the fact that is cystic, cyst, and then adenoma, glandular, or adeno, and then carcinoma because it's malignant. So rather complex, but if you understand papillary, serous, cystadenocarcinoma, okay, there's a type of the cystadenocarcinoma. Okay, so microscopically, the cyst is lined by properly orientated low columnar epithelium. You can see all these finger-like projections are lined by columnar cells sitting nicely on the basement membrane. The cells may be ciliated. This is a cystadenoma, so it's benign. The cells look fairly irregular around all the papillary projections, and you can't see the cilia on these columnar cells at this magnification, and the cells resemble tubal epithelium. Okay, yeah, but they all look pretty regular and uniform. The cystadenocarcinoma, however, the layers of columnar cells tend to be piled up. Okay, so multi-layered malignant cells showing loss of polarity, presence of solid tumors within the stroma. There is definite evidence of stromal invasion, and the papillae formations are more frequent and disorganized, and there may be associated sarcoma bodies represented in blue in this picture. Okay, and this is the histology stained with H&D, and you can see if you compare this with the benign variant, the serous cystadenoma, this one is more complex. The cells are more piled up, they're darker or hyperchromatic. It's just a more complex lesion. Okay, so this is the serous cystadenocarcinoma. The papillary outgrowths are more pronounced and more complex. And equally, the cells are also more complex and they had more abnormal mitotic figures, and there's evidence of stromal invasion. Okay, and then you have psammoma bodies. In fact, once we see psammoma bodies in this sort of tumor, the index of suspicion is very high that you are dealing with an ovarian papillary serous cystadenocarcinoma. Yeah? You can see stromal invasion, evidence of stromal invasion by this tumor. Then the mucinous variety, grossly, the tumors tend to be much larger than the serous type. The surface is smooth, the surface of the cysts, and typically they are multiloculated. Okay, typically multiloculated, so multiple cystic spaces containing thick, viscous, or gelatinous fluid. So, unlike the serous that has clear, watery fluid, this one is thick, viscous, and gelatinous. The benign tumors have thin walls, translucent septae in between, and the malignant varieties tend to be to have more solid areas. Okay. So this is the Mucinous cystadenoma pictorial presentation. You have a single layer lining of columnar cells lining the cystic spaces. The nuclei are basal with apical mucinous vacuoles, and the epithelial lining resembles intestinal mucosa. The mucinous cystadenoma generally doesn't have papillae or invasive tumor. And just as is in this picture, you have mucinous or gelatinous fluid, tall columnar cells, and vacuoles in the epithelial lining. So this is what it would look like, resembling intestinal mucosa, tall columnar cells with apical mucinous vacuoles and basal nuclei, and they all look pretty uniform in the mucinous cystadenoma. And then, of course, for mucinous tumors, you have the borderline that have features that doesn't have all the features of malignant tumors, but they are atypical. And then you have the malignant or mucinous cystadenocarcinoma. Okay, very similar to the way we classify serous tumors. Endometrioid tumors comprise 20% of all ovarian tumors. Majority are carcinomas. So unlike the serous and mucinous tumors, we don't quite have a good representation of benign endometrioid tumors. And if they are present, we think the cystadenofibromas are the benign variant of endometrioid tumors. They are distinguished from serous and mucinous tumors by the presence of tubular glands that have a close resemblance to benign or malignant endometrial glands. That's why they are called endometrioid tumors. 30% are associated with a concurrent carcinoma of the endometrium, 15% are associated with endometriosis, and 40% involve both ovaries. So this is an interesting group of tumors. 30% associated with a concomitant or concurrent endometrial carcinoma. 15% are associated with endometriosis, so ectopic endometrium in the ovary, and 40% are bilateral. So this is an example, pictorial example of endometrioid carcinoma. They tend to be generally solid with cystic areas, as in this, they have this sort of cheesy appearance, almost Swiss cheese, yellow with the cystic spaces of very variable sizes. And then on histology, you see these tubular glands that resemble endometrial adenocarcinoma. Clear cell carcinoma takes its name from the appearance of the cells, not gross, but the appearance of the cells. They have just this almost empty-looking cytoplasm with just a nucleus floating, a dark nucleus floating in there. They tend to be solid and may have cystic places and, with lots of necrotic areas. And microscopically, this is what you see: abundant, large, very large epithelial cells with abundant clear cytoplasm. The fifth example in that group of surface epithelial tumors is the Brenner tumor. They are uncommon, and we group them as adenofibromas because they comprise both a glandular component and a stromal component. So they're true adenofibromas, a mixed tumor. So epithelial components comprise nests of transitional cells that resemble the urinary bladder epithelium. Majority, luckily, are benign, and they vary in size from small tumors, 1 centimeter. Sometimes we see them as an incidental finding when we are sent an ovarian tissue, to large masses up to 30 centimeters. So 30 centimeters is the size of your ruler, so that's a huge tumor. And they tend to be solid with cystic spaces. The fibrous stroma resembles normal ovarian stroma and separated by sharply demarcated nests of urinary tract epithelium with mucinous glands. So it's a very classical. Once you see the histology of it, you actually just never forget it because it has such classical appearance. So grossly, you have a sharply demarcated yellow-white tumor. This is it. Occupies a portion of this surface of the epithelium. And then on histology, you have these nests of epithelial cells, tend to be fairly large, pretty uniform, and containing central cystic spaces. And this very classical, dense, fibrous stroma. Excuse me. The second group of tumors on our table are the germ cell tumors. They comprise 15 to 20% of all ovarian tumors. They arise from the germ cells, which are the cells that give rise to the oocyte. The germ cells are totipotential cells and capable of differentiating into the 3 germ cell layers. This is just the way they are because they are the ones that give rise on fertilization. They give rise to the human being. So they are totipotential cells with ability to differentiate into 3 germ cell layers. Fortunately, majority are benign and they are cystic, and because they are teratomas and with 3 germ cell layers, then they have this complex name of benign cystic teratomas. The other tumors in this group are found principally young adults. And they have similar tumors in the testes, in the male testes. There's no female testes, in the male in the testes. So you have similar germ cell tumors in the testes as you have germ cell tumors in the ovary. Okay. So the largest group are the teratomas. Majority, we've said, are benign tumors, and then followed by less common dysgeminomas or seminoma ovary, and the testicular, the concomitant or similar tumor in the testes would be the seminoma. Yolk sac tumor, embryonocarcinoma, or carcinoma with can be mixed with other types. So the embryocarcinoma can be a very, very complex tumor because it can be pure or mixed with other variants. So the teratomas, which are the commonest germ cell tumors, majority benign teratomas and comprise of mature adult type tissues. We shall see examples. Then you have immature malignant teratomas. The immature teratomas tend to be almost 100% malignant. And then you have the monodermal or highly specialized teratomas, and we shall see examples. So the mature or benign teratomas, they're the most common germ cell tumors of the ovary. When they are cystic, we often refer to them as dermoid cysts because they are lined by skin and hair and filled with sebaceous secretion. So dermoid meaning resembling skin. But in there, you may find other mature type tissues like cartilage and bone and teeth and other structures, including central nervous tissue or neurotissue. So really a whole variety of tissues. Remember, they arise from totipotential cells. So they can differentiate along all three germ layers. 10 to 15% tend to be bilateral. Fortunately, less than 1% undergo malignant transformation. The immature teratomas, which are always malignant, they are more rare than the benign cystic teratomas. They tend to be solid, they are bulky with areas of hemorrhage and necrosis, and they contain, in general, the reason why we call them immature is because they contain embryonic elements of all three germ layers. They tend to occur in adolescents and young women. And the way we grade immature or malignant teratomas is based on the immaturity, on the amount of immature neuroepithelium. So if you have neurotissue that is immature, then that's what we use to grade this tumor. They cause widespread extra-ovarian metastases, and the clinical behavior or the biological behavior is dependent on the immaturity of the tissues that are included in the tumor. Then the third variety of teratomas are the monodermal or specialized teratomas. And these are teratomas that differentiate not along all the three germ cell lines, but along a single tissue. For example, a monodermal teratoma may contain only mature thyroid tissue, in which case we refer to it as a stroma ovary. Okay, and then there are other varieties, but stroma ovary is probably one of the most common that we see. So the next few slides are just examples, photographs and photomicrographs of the germ cell tumors. So this is a benign cystic teratoma. You can see the cyst wall, and in there you have hair and probably other tissues that are not quite visible. And they are typically unilocular and can measure all the way up to 15 centimeters in diameter. And when you section the cyst, it is filled with paste-like sebaceous secretions, desquamated keratin, and a variable amount of hair. The cyst wall is thin, as in this case, and sort of opaque pearly gray color. And the cyst wall may also show solid prominence where tissues like teeth and bone and cartilage are present. And here is some photomicrographs, not the sharpest, but you can see the tumor. And here you have the cyst that is opened up, and you have all this matted hair admixed with sebaceous material. And again, benign cystic ovarian teratoma is multiloculated, filled with hair that is matted and with sebaceous material and fat. Another example, mature cystic teratoma or dermoid cyst, a ball of hair and other tissues are the ones that are making it look, the cyst thick in areas. Just to recap, the microscopic appearance of benign cystic teratoma of the ovary has a variety of mature differentiated tissues, and thus the varied macroscopic and microscopic appearance. So the ectodermal derivatives are the most prominent, with the cyst wall being lined by stratified squamous epithelium with adnexal, basically skin. Then other tissues of the mesodermal and endodermal origin could include bronchial tissue, intestinal epithelium, cartilage, bone, smooth muscle. Literally everything and anything can be in this tumor. Okay, so it's interesting. Okay. And here a histology to show mature cystic teratoma that contains cartilage, adipose tissue, ovarian, thyroid, mature thyroid tissue, and a variety of other epithelial lined spaces, which can include intestinal epithelium and so on. The second group in the germ cell tumor is the dysgeminoma. Remember, we said the equivalent tumor in the testes would be the seminoma. In the ovary, it's dysgeminoma. So grossly, the tumor comprises small nodules that vary in size, and this can be a very large tumor, small tumor, have this yellow, grayish pink appearance. It's often soft and fleshy, and the reason why it's soft and fleshy is really because of the microscopic makeup of this tumor. You have large, it's a very cellular tumor, very large vesicular cells with abundant clear cytoplasm, well-defined borders, centrally placed regular nuclei, and the cells are arranged in sheets and cords with very scanty fibrous tissue stroma in between. And there's often lots of mature lymphocytes in this tumor. Okay, so this is another example, a photomicrograph of this dysgeminoma or seminoma ovary. So firm brownish tumor, sort of nodular, separated by this sort of waxy stromal septi. Okay. So that's done in terms of examples of germ cell tumors. Now we'll go to the third group of sets called stromal tumors. And as we saw in that table, they include the granulosa thicker cell tumors that may be functional tumors if they secrete estrogen. Sertoli Leydig cell tumors, they generally secrete androgen when they are active. Fibromas arising from the stroma and may be associated with Meigs syndrome. The sex called stromal tumors that typically have annular tubules, the gynecoblastoma, and the steroid lipid tumors to complete the list. So we'll just look at a few of this. The classical example of this group is the granulosa thicker cell tumor. That's strange. I thought I had more. But you can read up on granulosa thicker cell tumor. I think it's a very interesting tumor. I thought I had more on it. But maybe before I share the slides, I can add an additional 1 or 2 slides on granulosa cell tumor. Then the last category is the metastatic tumors to the ovary. They are more common than we think. And the primary tumor can be from any of the abdominal organs, like stomach and liver and pancreas and so on. Even as far as breast tumors can metastasize to the ovaries. And when they do, particularly if they involve both ovaries, then we assign them this interesting name, Fruchtenberg tumor. And these are specifically bilateral metastatic ovarian tumors. They are composed of mucin-producing signet ring cells. And the most common primary is the stomach, but anywhere from the GI tract, intestinal tumors, both small and large gut, and the stomach are the most common primaries. They may produce pseudomyxoma peritonei, like the very well differentiated appendiceal tumors. So they have plenty in common with the appendiceal tumors. And they have a classical appearance. And this is a photographic representation of a Fruchtenberg tumor. You can see this huge tumor, predominantly solid with cystic spaces. And then this is the liver, and you can see there is also liver metastasis of this same tumor to the liver. In the histology, we said predominantly they have these signet ring cells, a sea of signet ring cells with very scanty fibrous tissue stroma in between. But the classical feature is the signet ring cells. So the signet ring carcinoma from the stomach is a common primary, okay? But of course, you know that signet ring tumors can arise from other organs in the GI tract as well. So gave you a short answer question, examples. One is to broadly classify ovarian tumors, which by now you should be able to do that. From our learning objective, we should be able also to describe some examples of non-neoplastic lesions of the ovary. So that's covered in question number 2, list 3 common non-neoplastic lesions of the ovary. And number 3, give 3 characteristics that we use in grading surface epithelial tumors of the ovary. Yeah, so part of your reading. And finally, we have lots of examples in the cabinet with ovarian pathology. I had asked Robert to put them out for you. Excuse me. So if you have, next time when you are at school, please pass through the museum and look at the variety of ovarian diseases of the ovary that we have for you. Okay. And if you have any questions, you can write me an email. Then I'll respond accordingly. Okay. Or even a message, a WhatsApp message. It's okay. So any questions so far? So I'm just done. I'm glad I covered in 1 hour because my throat is a bit sore. Any question? Any question from the chat? surface. You see, it's a marker that is produced by the coelomic epithelium that covers the surface of the ovary. Okay, so when you have a proliferation and a neoplastic proliferation of the surface epithelium, then CA125. So we use it as a marker of disease. Okay. Somebody is asking about lost pregnancies and I'm not sure we know that. We just know that narrowity increases the risk of ovarian cancer. So pregnancy was to term not may confer some degree of protection. Yeah. Somebody is asking me to show inflammatory lesion over. Can you see my screen? So I don't know how far back you want to go. I'll share this anyway, so not to worry. You have the whoever is asking the question. Yeah. I hope that is useful. No, I don't think oral contraceptives are known. They are not associated. No. Any other question or comment? Yeah, good. Can leave it there. I think I'll send